child health care breakout session. And I'm really pleased. My name is Joel Weathers. I'm with SIM. And really pleased to have Joy Mukaire from Christian Health Association of Sudan, as well as Adrian Allison from World Vision. And I'm really looking forward to hearing from both of you. So if you want to go ahead and get started, Joy? Rather than give a lengthy introduction that pretty much comes from the program, I'll let you read that later in the interest of time.
Good afternoon, everybody. Unfortunately, I didn't get a chance during the preparations for this conference to respond to Mona's request for introducing myself. So even in what they wrote, I think they decided, let's put this something and then she will show up. But my name is Joy. I have over the years, in the last 27 years, worked in community health, different countries. And I found myself in Sudan since 2007, initiating an interesting initiative of creating the Christian Health Association of Sudan. So this afternoon, I just want to share something briefly on some of the new approaches to very old problems that have existed in maternal and child health, particularly in this part of the world. The association, like I shared yesterday, will have a mission, and the mission is that all members will visibly and effectively participate in health service delivery and contribute to the attainment of outcomes for South Sudan. And that's the mandate. And then we focus on 4 areas, particularly health system strengthening, which includes the leadership, the advocacy, the health information system, and health workforce. We also focus on community system strengthening, which specifically speaks to what is true at the community level or required at the community level, the linkages, and the community activities. We also focus on scaling up coverage for priority health interventions for South Sudan, which in particular, like in this case, it is the maternal, reducing the maternal mortality. And then we do support advocacy and the creation of partnerships between the FBOs, the government, local government, and other organizations. The situation in South Sudan, like I mentioned yesterday, South Sudan has the highest mortality ratio in the world. It is 2,054 per every 100,000. It's real. Okay. And according to the household survey of 2010, it was estimated that 47% of pregnant women attend one or more ANC visits. Only 14.7% of deliveries are attended to by trained health professionals. Institutional deliveries accounted for just 12% of the births. Contraceptive prevalence rate is as low as 4.7%. Total fertility rate is 6.7. Individual life expectancy is 42. So we are dealing with a combination of issues. Okay. Next, please. There is widespread early child marriage at as early as 13 or 14 years for girls. Age of marriage is not well defined by the law. Sometimes the decision is arbitrarily taken by parents to marry off girls for a bride price. Early sexual engagement and pregnancy in young girls resulting to pregnancies with its attendant complications at delivery, leading to high mortality rates during pregnancy and delivery. High school dropouts among girls upon reaching the age of puberty. Girls are mostly kept out of school when they start their menses, as this is considered to be a sign of maturity and readiness for marriage. There is high literacy rates among adult population, 88% among women, 88, and 63 among men. or limited education opportunities due to the war and the breakdown of the whole infrastructure. There is sexual exploitation, including rape against girls. The criminology in rape is lost under the disguise of cultural norms, and most communities treat rape as part of initiation. And usually, you are asked or forced to marry whoever has raped you. Gender-based violence is common, particularly rape, which ends up in forced marriages, like I've just mentioned. Cultural practices like ghost marriages contribute to early marriage, where if you lost a brother, particularly an older brother during the war, you have to marry for him. You know, you first marry a wife for your late brother. Get children first, then marry your own. Okay, so that's a common practice, particularly among the Dinkas. The Minister of Health, in one of the international high-level meetings in Dakar, did say the following, did make the following statement, which statement shows the commitment on the part of government. He said the legacy of the more than the two decades of gruesome war for independence of the Republic of South Sudan is more evident in the health sector, where there is almost total collapse of the health system. He also notes that an estimated population of 10 million live in squalid condition, faced with a very serious disease burden, with the world's highest maternal and infant mortality rates at that level. The best and prudent response to this scourge is to put in place a robust and vibrant primary health care system, focusing on mother and child health care, especially family planning. He continues and says, we are aware it is a daunting task, but we are committed to our vision of ensuring a healthy and productive population capable of exercising its human potentials. He continues and says, besides that, the one maternal death of one infant child death is too expensive and unaffordable to us at this point in our history. So that is the Minister of the Republic of South Sudan in 2011 in Dakar in December. In that meeting, he did express the commitment, recognition of the problem, the commitment, and what he thinks would be the case if they didn't pay enough attention. So the strategic response, according to the Ministry of Health 5-year strategic plan, is to improve delivery of maternal and child health interventions through making relevant services accessible and acceptable, especially obstetric services and integrated disease prevention and control programs, with 3 objectives: increasing service utilization and service quality, which speaks to the demand, increasing health promotion and protection, strengthening institutional functioning, including governance and health systems effectiveness, efficiency, and equity. So it is within that framework that CHAS, as a partner with the government, wishes to scale up the frontier, particularly for maternal, reducing maternal mortality. As earlier mentioned, 88% of the women deliver in the hands of the traditional system. And therefore it is very difficult for you to find them unless you partner with the traditional system. So the new way of looking at it was for us to begin to think that traditional birth attendants represent one of the practices of traditional healing system and constitute the majority of healthcare delivery in addition to family members. This system is neither trained or have any form of technical support in modern midwifery. However, highly trusted and respected by communities, and could effectively promote and facilitate PMTCT enrollment, uptake, and family planning, and every other service that we wish the women access. This is the rationale for us to go to the midwife, to the traditional birth attendant, because they hold the clientele we need. So scaling up the frontier began particularly through an HIV/AIDS program where we had the task of integrating PMTCT into ANC. But ANC services did not exist in most cases. So PMTCT programs are established in some government hospitals and health centers, but neither exist in private clinics nor in rural areas where majority of the women still deliver. It also appears relevant and logical to transform the role of the TBA and explore their involvement in HIV PMTCT programs. TBAs recognize, when we interacted with TBAs through some formative research discussions, TBAs recognize the link they have with institutions, institutionalized healthcare at facility level, and are also aware and have experienced challenges in providing services or handling certain cases where they have limited skills. They know that. They have expressed that. They are desperate. They are desperate because the community is forcing them to provide the services they feel they are not prepared for. Other assessments also point to the need and desire of TBAs to be trained in order to follow up the required obstetrical practices for HIV PMTCT. We believe this is a case for community systems strengthening, so to say. It is a case of moving the TBAs and their clientele closer to the facilities for support, for supervision, and skills upgrade. We also think that we need to create a network of between FBO facilities, or we have actually created a network between FBO facilities, outreach workers, and TBAs for possible continuum of care. If they miss it from this side, they can get it from the other side. If they need it from the other side, at least there is a link. So most of the there are some selected sites where we have begun this effort, where the FBO facility is aware of the number of TBAs, and the TBAs are aware of the facility, and the two are working together, and the facility has even created space for the TBA to come once a week to bring the mothers once a week or whenever she feels like, but operate from within the facility. We also think upgrading skills of TBAs in how to improve safety of delivery services that they are already providing, and supporting them with basic equipment like torches, gloves, aprons, clean gauze. In fact, we have distributed them with a small kit. I was looking for the picture last minute, I didn't find it, of a small kit, which kit is a kit that they require, which has some essentials in making the delivery safe in case the delivery has to happen. But if the delivery is not happening at the house, at her house, then she really has to refer, and she has to know when to refer. Okay? We have also embarked on supporting community advocacy for creating a supportive socio-cultural environment. Like I mentioned earlier, the environment is not cognizant of the problem. The cultural leaders are not aware. The husbands are not aware of these dangers. The religious leaders, we have put them through a training for them to understand that it is our call and duty as faith-based to save the mothers